We have a small but mighty crew here in the nursing building and a lot more people online. So welcome to everybody. I'm Bob Walker, Chair of the Department of Medicine at UCSF. Today's Grand Rounds is immune effector cell therapy in hematologic malignancies, an incredibly exciting area. If you look at the way we take care of hematologic malignancies, it is massively different than what we did as recently as 10 or 15 years ago, and making an enormous difference in the lives of our patients. And we're lucky to have a world-class program in hematologic malignancies, not only in delivery of clinical care, but in research and education as well. And we'll hear today from two of our leaders. Babis Andreadis is professor in the Hem/Onc division based at UCSF Health. He's also director of the Baszucki Lymphoma Therapeutic Initiative for our cancer center. He studies drug toxicity and genetic and patient factors behind differential responses to lymphoma, leukemia, and myeloma. Babis got his MD at Columbia, did his residency there at New York Presbyterian, and then his Hem/Onc fellowship at Penn, and we were lucky enough to recruit him to UCSF, and he's a fantastic member of our faculty. And he's joined by Ajay Chari, who is also a professor in the Hem/Onc division here at UCSF Health, and is now director of our multiple myeloma program. He is a national and I'd say world leader in the development of novel chemotherapeutic regimens for myeloma, a disease that used to be uniformly fatal and now has remarkable improvements in prognosis, in part based on some of the pioneering work that Ajay has done that's been published in the top journals. Some of the really most important clinical trials that have helped our understanding of myeloma come from Ajay. He trained at Stanford as an undergrad, MD from UCLA, then made the move east, also to Columbia, then did his Hem/Onc fellowship here at UCSF, joined the faculty at Mount Sinai, was there for many years, and established his role as a national leader in this area. And we were lucky enough to recruit him back 2 years ago. It's all blending together, but and to help lead our myeloma program. So thrilled to have them both here. And I think Babis is going first.
Okay, thanks, Bob, for the introduction. Thanks for having us talk about something near and dear to our hearts, which is immune effector cell therapy in heme malignancies, lessons learned. The reason why we called it lessons learned is we wanted to focus on some of the toxicities and longer term issues that seem to arise in the patients being taken care of with these therapies, as I think most of us are familiar with the successes of the treatment. But first, we will take turns going over the revolutionary achievement that immune effective cell therapy has been for lymphoma and myeloma. Then we'll go over some of the established toxicities of the treatment. We'll go into kind of some of the emergent issues from this therapy, and then talk about future directions at UCSF. So we hope to be able to do that pretty smoothly over the next 45 to 50 minutes or so. So just a quick introduction. So I'll start by talking about lymphoma, and then Ajay is going to talk about myeloma. So the most common non-Hodgkin lymphoma is diffuse large B-cell lymphoma. It's kind of the paradigm of all lymphoma therapy, and most of the developments emerge in this field. It's a very aggressive disease, as many of you know, but it is curable with a combination of immunotherapy with an antibody and chemotherapy in the frontline setting. Unfortunately, for patients who are not cured with frontline treatment, it can have very dreaded outcomes, with only selected patients being able to be cured with second-line therapy, historically stem cell transplant. So these are the outcomes of refractory or early relapse diffuse large B-cell lymphoma based on a large series of studies that have been included in this meta-analysis prior to the CAR-T era, which, like Bob said, was only 7 years ago. And that's, you can see that long-term outcomes are pretty poor, with about 20% of patients achieving long-term remissions. I was in the audience at the American Society of Hematology meeting when this late-breaking abstract made a splash. It was the introduction of Axi-cel, the first CAR T-cell therapy to be FDA approved for diffuse large B-cell lymphoma. And these are the long-term outcomes now. This is the same patient population that I showed you before with 15 to 20% long-term disease control rates, now getting something in the order of 30 to 40% long-term disease control rates and overall survival. So this has really revolutionized the field. Just to go very quickly, for those of you who don't appreciate what a CAR T is, which is the therapy that we're talking about. So it's a chimera. It's made up of, let me switch to the mouse. It's made up, the reason why it's called chimeric is because it incorporates an antibody and parts of the T cell receptor in the same molecule. So it's made up of an antibody domain recognizing a target, in the case of lymphoma CD19, in the case of myeloma BCMA. And it also has internal signaling domains derived from a T cell receptor. So usually parts of the CD3 molecule, and then a co-stimulatory domain, usually 4-1BB or CD28 or both. And the process of producing autologous CAR Ts, again, is pretty straightforward, but includes leukapheresis and isolation of peripheral blood mononuclear cells, then using a viral vector, not always, but in this case, using a viral vector to introduce this chimeric, this gene expressing the chimeric protein into the cell, and then reinfusing the product back to the patient, usually with a 3 to 6 week delay. Since that original presentation that I showed you from 2018, there's now 4 FDA-approved CAR T-cell treatments in lymphoma, with primarily working in aggressive lymphoma, but also in like diffuse large B-cell, but also in follicular lymphoma, mantle cell lymphoma, and most recently in CLL. This is a slide that I borrowed from Dr. Komanduri, who's sitting right in the audience. So it's pretty quickly, based on the success of the treatments for relapse refractory patients, pretty quickly CAR Ts have moved into the mainstay of treatment for lymphoma, with 3 randomized studies for early high-risk patients, comparing CAR T-cell treatment to either chemotherapy and stem cell transplant, and showing that CAR T-cell therapy is superior in terms of both event-free survival and overall survival in one case. So this has now become a very active therapy for all patients with relapsed refractory lymphoma. What are the problems that we face as we try to bring CAR T to the mainstream? Number 1 is patient eligibility. This is a very expensive therapy, as people can imagine. The cost of the drug only, it's about $500,000. That doesn't include all the procedures and bills that patients incur. So it has to be FDA approved. So problems to access to CAR T include the diagnoses that are covered. Also, patients' ability to undergo such a treatment. Access is a big issue in CAR T. I call it a boutique kind of therapy because it's only available at selected institutions around the country. Now, there's more and more institutions that do it, but still access for patients is pretty limited, and involves several steps that are very delicate and can go wrong, that are listed here. And lastly, I think a big issue is management of toxicity of CAR T, which we'll go into a little more detail. So to study the generalizability of this treatment, we joined early on the US CAR T consortium that includes all of the institutions listed here, where we tried to see how patients do outside of clinical trials and identify long-term trends in the care of these patients. Not surprisingly, one of our early endeavors was to see, well, are the patients that are being treated with CAR T outside of a clinical trial similar to those who enrolled in the pivotal study? And we found that 40% of patients in our consortium, as many as 80% patients in European consortia would not have been eligible for clinical trials. So we're expanding the availability of the product outside the strict approval. And this graph just shows that patients who were not eligible for the who were ineligible for the study. So no is eligible, yes is ineligible, have worse outcomes than what were described previously, but still can do really well with this approach. So it's a matter of patient selection. I'll close the lymphoma section really quickly by going into bispecific antibodies. So bispecific antibodies are a new class of antibodies that have been around for a while, but new to myeloma and lymphoma in that they target two areas. So usually they will target a traditional antibody target like CD19 or CD20 in lymphoma, but they will also target CD3, which is on the surface of T cells, essentially bringing the T cells in the vicinity of the malignancy and turning the tumor into an antigen-presenting cell that's activating T cells. So these are antibodies that are off the shelf available for patients and can produce immune responses, sometimes as good as CAR T cells with very little toxicity. So this is one that we were part of the pivotal study for epcoritamab that targets CD20 and CD3. And you can see that in high-risk patients, we can get reasonable response rates and long-term progression-free survival with this approach. So the paradigm for treatment of diffuse large B-cell lymphoma in 2024 has shifted dramatically in that we still start with chemotherapy. That may change in the near future as frontline bispecific antibodies are maturing. But then for patients who have relapsed or refractory disease, we will quickly go into immunotherapy, whether with CAR T or with bispecific antibodies. And so the field has dramatically changed over the course of the last 7 years to be very immunotherapy oriented. Dr. Chari.
Hi, it's a pleasure to be here. And interestingly, Babis was in medicine. Babis was my second-year resident when I was an intern. So it's full circle back here. So I used to be biphenotypic. I did in fellowship lymphoma and myeloma, but then I differentiated. And so I've always had a little bit of lymphoma envy. And there, the pathologist can tell you what subtype of lymphoma you have. And they're treated differently and look at the outcomes of their patients compared to healthy controls. And this is myeloma. So we have a big gap in terms of patients versus the age-matched control. So we need to narrow this gap. So when I started my fellowship here, we basically had steroids and conventional chemos. And as Dr. Wachter said, it was median survival was on the order of years, a few years. This is what it looks like now. And this is really remarkable. We have IMiDs, PIs, immunologic approaches, XPO inhibitor. One thing I always like to mention is that every monoclonal antibody that exists in human beings owes its legacy to myeloma. Because in 1984, a Nobel Prize was given for fusing a myeloma cell with a spleen cell, and that hybridoma gave antibodies. And yet, the first monoclonal antibody did not approve for myeloma for almost 30 years. So even though we helped the world with these antibodies, we finally got this panoply. What's particularly striking is myeloma is only the 14th most common cancer. And on average, it can take up to 9 years to take a drug from first in human to approval. So to see this kind of pace of activity, I think is really astounding and incredibly gratifying. So today we'll be focusing on the 3 bispecifics, talquetamab, teclistamab, elranatamab, that are now commercially available, and then the 2 CAR Ts known as ide-cel and cilta-cel. So why pick these targets? Well, in general, we want to pick targets, obviously, that's selective to the tumor, but not so much other cells. But nothing is that perfect. There's always a little bit of dirtiness. And in the toxicity portion of our discussion today, we'll see that. But basically, there's a lot of efforts in immunology in myeloma, targeting not just myeloma, but NK cell, T cell, macrophages. And the 2 that I've shown are BCMA and GPRC5D on the bottom. And the red arrows indicate internalization. And that's important because if an antigen is internalized, it's also a potential target for an antibody drug conjugate, because then you could potentially deliver a toxin not only to the surface of the cell, but internalize it and really get specificity. So this is really what's amazing in myeloma. So historically, you saw on the left, pomalidomide, carfilzomib, dara, selinexor. So the way oncology drug approvals work is you take an unmet need. So patients have exhausted all their therapies, and you see that it can demonstrate some kind of a response rate, some kind of a remission rate, but these are what's called accelerated approval. So you don't have a control arm. The goal is just an unmet need. You want to show what the response in PFS. And historically, it was pretty low benchmark, 20 to 30% with a PFS of 4 months. And now you can see on the right side with these novel immunotherapies, they're blowing these out of the water, right? So we're seeing response rates in blue of 60 to 98% and PFS of 1 to 3 years, which, keeping in mind, the approval for all of these is at least 4 lines of therapy in IMiD, PI, and CD38 exposed. So not only are you getting more deep responses, more durable responses, these are in more heavily treated patients than these historic outcomes. And if I had to paint a picture of this from a patient perspective, one of the most difficult things about leaving New York was I got patients, I was there 18 years, and I was privileged to have patients follow me around for those time. And then we were reflecting as I was saying goodbye to some of them. Some of them had even spoken at the ODAC meetings for some of these early accelerated phase. And we had hospice discussions, right? Because they had exhausted every drug available. And now those same patients are in some of their most deep and durable remissions on these therapies. So it's really a paradigm shifting time in myeloma. And it's so gratifying, I think, to be part of this field. So now talking about these agents on the right, they all target the same antigen, BCMA. So why BCMA? This is a receptor for B cell transcription factors known as BAFF and APRIL. It's expressed primarily on mature B cell subsets, but you can see in the ontogeny of B cells, it shows up relatively late and then in plasma cells specifically. When you knock these out in mice, you get normal B cell numbers, but impaired plasma cell survival. So lends credence to the effort. You already heard from Babis about bispecific. I would say we're not only doing bispecifics, but now trispecifics, right? Why'd you stop at 2? And so these are some examples of structures. There's small molecules where they don't have the FC portion, but they have an albumin portion to help extend the half-life. And then you have agents where there's 2-to-1 binding domains. There's some that are tetravalent. This is the trispecific, which actually binds CD3 and 2 different myeloma antigens. So a lot of innovation in the structures. And also we're looking at the affinity, right? CD3 affinity, it's kind of shocking that you have a median age of 65 to 70 with a median of 5 to 6 lines of therapy. No one thought their T cells were even functional, let alone giving these responses. But now one company even decided to go with a low CD3 affinity, and a lot of skepticism because we didn't think it would work. But not only is it working, but it's seemed to be quite well tolerated. And there's also efforts looking at NK cell engagers, but those are much earlier in development. So the 3 bispecifics that are approved kind of share all the similar structure, the standard FC portion with CD3 binding domain and a target domain. 2 of them are BCMA, 1 is GPRC5D. And at this point, we want to switch gears a little bit to toxicity.
We won't be doing too much of the flip-flopping, but we think it would. So we obviously have shown how effective these therapies are for patients, but we wanted to really have more of a discussion about emerging toxicities and understanding of how to take care of these patients in the long term. So what are the traditional CAR T toxicities that we encounter in the first month or 2 of treatment? There is usually a lymphodepleting chemotherapy regimen being given for these patients. So the number 1 toxicity is cytopenias, usually due to the lymphodepleting chemotherapy. It can also, however, be exacerbated by the immune response. So it can be long lasting, as I will show you later. The next toxicity, which is kind of a desirable one, is tumor lysis. These patients get very dramatic, quick responses. So we see a lot of actual tumor lysis with elevated LDH, uric acid, and acute kidney injury. The classic CAR T toxicity is cytokine release syndrome, which is an immune activation as soon as the cells start encountering their target and proliferating. And that is traditionally characterized by fever, hypotension, and hypoxia. It's usually self-limited and manageable with steroids. The dreaded encephalopathy syndrome, or ICANS, which is still poorly understood, but probably has to do with the weakening of the blood-brain barrier in the course of the immune reaction, and can have many manifestations. it's harder to manage and can be longer lasting. And lastly, severe immunosuppression, which we'll go into some more detail. So both of the products that we're talking about, whether they're targeting lymphoma or myeloma, they target antibody-producing cells. So they generally produce a B-cell aplasia, but also severe hypogammaglobulinemia and lack of responsiveness to immunizations. Just to put in perspective why that can be an issue, this is an early slide from one of the studies that we're involved with, looking at persistence of the chimeric antigen receptor T cells in blood, showing that it can be many. Here it's many months, many days, but the Penn group has shown that they can find these T cells in the blood for 10 years or more. These cells will continue to exert their effects long after they are given. So at the consortium, we recently presented this data at ASH, looking at the first CAR T that I described, Axi-cel, and looking at the 5-year follow-up for our group. So I told you the good news initially that we are seeing very long durations of response, so 30 to 40% range, and this is 5 years out, confirmed by the follow-up. But what is more striking is even though the relapse risk, and I need a thing for that. So this is, can you see this much? Okay, so the blue curve is the risk of staying relapse free. Okay, so I'm sorry that it's portrayed like that. But anyway, so the risk of relapse is very high in the first 6 to 9 months, but then stabilizes over time. However, the risk that is continuous and increasing is that of what we call non-relapse mortality. So patient death related to the treatment, but not to the disease or any other factors. And you can see that that risk is pretty stable over time. And by the 5-year mark, it had reached 16%. So 16% of patients who received this therapy died from a toxicity. The number one cause of death among the non-lymphoma causes was infection. And again, that points to how severe this immunosuppression is. Of course, these therapies were developed in the COVID era, so many of those infections are COVID related, but many are the classic and viral or bacterial infection that we see in patients with hematologic malignancies. I will also talk about secondary malignancies, which is an emerging problem with these patients. In terms of infections, we can see here that even at the second year following, so the first year after treatment, there's 17% of infections can be severe. Even in the second year, we're seeing severe infections, and we're seeing prolonged cytopenias that can last up to 2 years. Sorry, this slide didn't turn out that well. It's fine. Very importantly, immune cell recovery. So you wouldn't think that stimulating T cells and injecting them into a patient would cause a T cell depletion, but in effect it does. It's not really just related to the lymphodepleting chemotherapy. It probably has to do with skewing of the immune repertoire in the process of doing that. And so if you use a marker of a CD4 count of greater than 200 as immune recovery, you can see here that at 1 year, only 38% of patients have achieved the CD4 count above 200. At 2 years, it's 73% of patients that have a CD4 count above 100. So it's pretty prolonged immunosuppression. B-cell recovery is much worse. So we're looking for any B cells here, not a 200 number. So 0 is the cutoff. So at 1 year, 50% of patients have detectable B cells. At 2 years, 57% of patients have detectable B cells. So you can understand why this immunosuppression is so severe. An emerging problem with these therapies has been secondary malignancies, subsequent neoplasm. Again, having to do with 2 things. One, the number of prior therapies that these patients have received for their hematologic malignancy, but also the immunosuppression that comes with this disease that affects immune surveillance of oncology. So about 7% of patients were diagnosed with a secondary malignancy. And the most common ones are myeloid neoplasms, MDS, AML, or CMML. Again, these are very heavily pretreated patients, like Ajay said, with many of them having received median of 4 prior lines of therapy. 36% of them had received a prior stem cell transplant, but that is a significant problem. Additional toxicities, Dr. Chari.
This is a case actually from my prior institution at Mount Sinai. So this patient had myeloma and had cilta-cel, was in complete remission. But then he presents with fatigue 3 months after the CAR T. And you can see initially he had high-grade CRS, and then he had neutropenic fever. But then on day 100, he presents with mask-like facies, bradykinesia, tremor, fatigue, postural instability. And the functional imaging actually showed decreased FTG uptake. You can see pre-CAR T, he happened to have a PET scan that was able to be looked at in the basal ganglia pre versus post. And the most significant drop was in the caudate nucleus. Unfortunately, this patient passed away because of the difficulty of controlling this Parkinsonism. On postmortem analysis, there was gliosis with T cell infiltration. You can see the CD3 positive staining in the caudate nucleus. And there was also BCMA expression was demonstrated in both the astrocytes and the neurons on the top and the bottom. So this is really devastating. You have these patients who are in complete remission, who lose cognitive function, motor function, and we really don't know what to do with these patients. And it's pretty rare, but it is a known side effect. And Dr. Kumar, who's sitting in the room, I'm excited that she's going to be the global leader in this, because to understand this, you need to collect data from all the centers, because this is too rare for a single center. We at UCSF so far have had 6 out of around 70 cases. And we're going through collaborations. One of the great things about being here is the tremendous opportunity to work with the interdisciplinary colleagues. We joke in myeloma, it seems like it's so specialized. There's like a left eye uveitis clinic, right? Not just uveitis. So we're fortunate to have not just neurologists, but neuroimmunologists that are helping us to novel cytokine analysis on spinal fluid. We see some preliminarily filament and immunologic changes in the spinal fluid. It's not just CAR T, because the presence of CAR T in spinal fluid is neither necessary nor sufficient. It's something more than that. And so to really get a handle on this, right now we're throwing things at these patients. We're trying intrathecal chemo, systemic chemo to try to ablate the CAR. And sometimes all you get is, unfortunately, what happened with this last patient, which is sepsis and death by trying to ablate the immune system in an already very immunocompromised patient. The same thing you heard about lymphoma is happening in myeloma. I would say it's probably even worse, because our patients tend to be older. Median age of myeloma is 65 to 70. They tend to be more heavily treated than the lymphoma. And so in the initial CARTITUDE-1 study, MDS, AML were found in about 10% of patients. The median time was about 485 days. So, and I'm focusing on that because that's a relatively short latency. It's not like this was years later, right? So you get your CAR T, and about a year and a half later, you get these myeloid neoplasm. 9 out of the 10 died, 4 of them after starting a new therapy. And these have also been mentioned in post-marketing. But these 10 patients had a median of 7.5 lines of therapy. And this illustrates, while we love those accelerated approvals that I showed you on that first slide, because literally if your patient has exhausted all therapies, you don't have 9 years to wait for phase 3 studies to complete to get full registrational approval. But the problem with accelerated approval is that you cannot separate out patient factors from disease factors from treatment factors, right? There's no control arm to isolate out the variable. It's easy to blame CAR T, but is it because these patients had 7.5 lines of therapy? And the second thing is that accelerated approval, by the nature of their purpose, is they push the doses and intensity. In CAR T, it's a little bit different, but with bispecifics, you go for max for highest dose tolerated for as long as you can give it, because historically myeloma remissions were short, right? So now we're seeing these amazing responses. We're actually having to go back and say, maybe is this too much? But to the first point about we don't have controlled studies in the accelerated, we actually now have controlled studies for both ide-cel and cilta-cel. So these are known as KarMMa-3 and CARTITUDE-4. I'm not going to go through these details, but they're there if you're interested. Basically, they compared the CAR T to standard of care. And what you can see is that ide-cel 13.3-month PFS versus 4.4, median not reached versus 12. one of the things that we're struggling with myeloma is we have so many options. And again, you're always taught in medicine not to do cross-study comparisons because they're different. And that is true. You can see, for example, standard of care did 4.4 months versus 12 months. So clearly these are different populations, different lines of therapy. So one way to contextualize that is to look at the hazard ratio. So I didn't pay attention to hazard ratios until probably 10, 15 years ago because we got so many options. Now you can see the hazard ratio is 0.49, 0.26, meaning 75% in the likelihood of progression or death with cilta-cel. And how does that compare? Well, when you look at other pomalidomide dexamethasone backbones, those hazard ratios were about 0.6. And so this is significant improvement, both are. But one of the criticisms is that there's also other options like CD38 KD, like daratumumab, carfilzomib, and dex. These have really impressive PFS, right? Almost 33 years. And so some criticize these CAR Ts because they picked kind of wimpy control arms. But the way drug development works is you pick whatever you had at the time, and that is what it is. But I show these because you can now ask, all right, so these, and by the way, these both led to FDA approval last week. So both of these phase 3 studies led to approval, which means we now can give CAR T not just in 4 or more lines of therapy, 1 to 3 lines of therapy. Of course, we need UCSF's help to get more spots in apheresis and nurses and machines, but that's a side note. But what about the secondary malignancy? When you move up from those heavily treated train wreck patients to 1 to 3 lines, do you see a difference? Well, now we have a control arm, and you can see cilta-cel had 3 patients with heme malignancy versus 0 in the control arm. It was 1 AML, 1 MDS, 1 peripheral T-cell lymphoma. So maybe not as bad as the 10%, but there's something here. And again, this is relatively still short follow-up, 15.9 months, but stay tuned. Another thing this study highlighted for us was really how not off the shelf we have these products are, right? So somebody came up, I like the term brain to vein time. From the day you think about a CAR T to actually you can give the CAR T, you need to get insurance approval. You need to get a apheresis slide, collection, manufacturing, and infusion. And guess what? In that time, the disease is not sitting pretty. And even with a median of 2 prior lines of therapy, when you look at the cilta-cel curves in the first few months, cilta-cel is actually worse because there are patients dying from myeloma while they're waiting for CAR T. And in fact, when you look at the breakdown, there's cilta-cel who, in patients who got it, there was deaths in the dark blue, but there were patients who never got to cilta-cel, 12 patients, because their disease was too rapidly progressive. And there were also patients who progressed during the time from manufacturing to administration. And the problem with those patients is when you go into CAR T with worse disease, you get higher grade CRS, more risk of neurologic toxicity. So we really need to pick the right patients. Switching gears a little bit to the bispecifics, I want to just focus on a few salient differences. And one thing I want to call your attention to on this slide is let's look at infection, which again is across the board for both myeloma and lymphoma. The CAR T rates of infections were about 60 to 70% all grade, and high grade was 20%. When you target that same antigen, BCMA, with a bispecific, you now get 80% infections, 55% grade 3 and higher. These are some of the highest rates of infections I think we have in medicine. If I had to give you an example, I get angina thinking about this patient. One of my patients in New York went to the ER with chest pain. Turns out he had pericardial tamponade, and when they drained it, it was a Neisseria subspecies, which I'd never heard of. Another patient went to the hospital with a pneumonia and required a chest tube for empyema. Things that we just don't see that much, but these are the train wrecks that we're getting. And yet it's the same antigen. And it shows you the difference between the kind of one and done target with a CAR T and the repetitive targeting with a bispecific. So what do you do about that? Well, first, I should mention that BCMA bispecifics universally will give you 0 IgGs. If you don't do anything about it, everybody's IgG will go to 0. So one thing you can do, and this goes to my point about accelerated approvals, pushing that dose intensity. We now know that maybe you can back off. When you go from weekly dosing to every 2 weeks, that can lower the rate of infection. This is work from Mount Sinai. One of my former fellows who's now in faculty at Princess Margaret in Canada showed that we showed that the IVIG can markedly reduce the rates of infections, particularly grade 3 to 5 bacterial infections had a 90% reduction. And another group from Europe showed similarly that primary prophylaxis can really help. This is not a prospective study, but I don't think we have room to wait, right? When you have a 55% grade 3 infection, we're basically starting IVIG from the get-go. And another drug that I've been very privileged to be involved with, we actually had 70 patients on the phase 1 dose escalation study for this compound just because of the unmet need. And this is the only product targeting a non-BCMA. It's called GPRC5D, G protein coupled receptor class 5 member D. We don't really know a lot about this. It's an orphan receptor, lignin signaling unknown. Unlike BCMA, there's no shed protein, so there's no binding sink for potential targets. It's overexpressed on myeloma, but also in heavily keratinized tissue, which leads to some of the unique toxicities. So we do see rashes and also something palmar plantar peeling. The management is typically emollients, topical steroids for the rash, and systemic steroids for the high-grade rash. Also, nails are heavily keratinized, so we see nail changes. But one of the unique things, this is the only product in myeloma where we see that the AEs correlate with response. So patients who have these AEs have a 20% higher likelihood of having response. So probably this is an on-target off-tumor effect that unfortunately we have to deal with. Good news is that reducing the dose intensity has mitigated it. One of the most debilitating symptoms is actually dysgeusia or loss of taste, and that has been mitigated with that. So finally, a brief word on what we're doing at UCSF. Yeah, I'm gonna say
Yeah, so so this is what we tried to cover a lot, but we wanted to end with what's happening in terms of trying to improve access to these therapies and also develop newer and more exciting targets. So it, as it always does, it always starts with lymphoma. It started this homegrown CD19 study where we make our CARs internally. By internally, I mean at the UC core facility in Davis. We're planning to shift production actually to UCSF in the next year or so, but right now the cells are made there. We're using the so-called Prodigy equipment, so the Miltenyi kind of processing platform to develop these cells. We are getting them at a cost of about $80,000 a product, which is a lot lower than the $500,000 a product that they cost to make commercially. And we're treating pretty much all comers with lymphoma, not restricted to just the FDA approval. So all of the indications are shown here. The good news is so far we've treated over 17 patients, and as you can see here in green, the majority of patients with different lymphoma histologies are getting complete remissions that are long-lasting. The longest remission is about 3 years now. And we're doing that with very little toxicity. So both CRS and ICANS, the dreaded neurological toxicities, are very low. Max grade of CRS was 2 and max grade of ICANS was 1. So with the foundation, the Bazooki Foundation grant that we received, we're actually preparing a next generation homegrown CAR T study that will involve one of the new targets that Ajay will talk about.
So yes, myeloma is a little behind here about this, but not that bad. So what's happening here, I think super exciting. Obviously, CRISPR technology was used to now develop, Justin Equium in 2021 developed a novel CAR. There's novel targets like CD70, RASA2 that are being developed. That we have a similar homegrown version 1 of what Babis has mentioned. But there's also really exciting Tom Martin, who's a brilliant clinician scientist, and the reason I went into myeloma, he got a $4.6 million grant recently from the Serum Institute for a homegrown TRAC locus. So what's unique about this product? So currently, all the CAR Ts are using lentiviruses to do the integration of the chimeric and receptor. Now we're using CRISPR technology. So you know where you're going to go, and you can actually pick a locus. And what's unique about the TRAC locus is, unlike current CARs, which have constitutive signaling that can exhaust the T cells, this one can actually internalize and not lead to that exhaustion. So this is going to be homegrown 2.0, and that we're excited to get that into patients very soon. So our conclusions, I think you've seen both in lymphoma and myeloma, unprecedented responses that are really changing the natural history of these patients. The type of response just depends on the subtype of the disease. We're seeing some cures with lymphoma, maybe myeloma too. Access is still limited. This is a big problem because the bulk of patients with these conditions are not being treated at academic centers. They're treated in the community. So these off-the-shelf bispecifics are really a big advance. We have obviously important toxicities we need to go through and really exciting novel CAR Ts and bispecifics. And with that, thank you for your attention, and we're happy to take any questions.
Thank you. We've got plenty of time. So let me start with a few. So cures in lymphoma, how far out does someone have to be before we know that they're cured? And the same thing, I guess, is true in myeloma.
Well, so cure is obviously a complicated word, but with aggressive lymphoma, usually after 6 to 9 months, you have a 95% chance of staying in remission for over 5 years. We are seeing some late relapses, but it's 1 or 2 percentage points.
Wow.
Right now, we probably have about 5 to 10% of patients which are being cured. But in fact, some reviewers will reject journals, articles that say myeloma is incurable. But the problem is that you need to go a lot further out. You probably need to go at least 5 years because otherwise you see the disease coming. And with cilta-cel, one of the products, there is seeming to be a plateau, maybe about 20% that have gotten to past 3 years. Whether that holds out, we'll have to see.
And do you have any sense of, it sounds like part of the problem is in order to get through the FDA process, you have to use all of these treatments so late in the course. People are already been through the war with 2 or 3 other lines of therapy, and they're probably different people than they were at the start. Is there any way of extrapolating what it would be if you gave these therapies to someone as a first-line therapy?
So we've seen this in myeloma with a couple of studies. So far, I showed you those randomized phase 3 studies with preliminary follow-up. I don't think it's working that much better from my gut says. And also we have some patients that were studied with like functional high risk. So where their myeloma relapsed early, so they were allowed to get it at 1 year. Ide-cel, which is that kind of less effective product, has not seeming to work differently in less heavily treated patients. Cilta-cel we have to see, but I think the bigger issue is probably not going to be so much improved efficacy, it's better safety. Less progression, less neurotoxicity, less high-grade CRS. I think the safety profile might be better with less.
Because you can use lower dose, or
Because you
because
can
their
go into-
body is not as beaten up?
Because you can go into CAR T with better disease control, right? You have other drugs to control the myeloma or lymphoma rather than waiting for extremis, and you're then forced to give a product with full-blown disease and you can't do anything about it.
Yeah.
So that's I haven't heard that about myeloma before.
That's why you come to
That's
Glenn.
not surprising.
Yeah.
That's why we're having a discussion.
Exactly.
No, it is absolutely true because the pivotal studies were in 3rd line or beyond, and then the 2nd line studies obviously were in 2nd line, and we don't see a difference in efficacy between the actual T cell product. So you would think T cell function would be better, but it doesn't seem to make a difference. And I wanted to just highlight something that Ajay said. Disease control makes a difference in toxicity, in acute toxicity. All studies show that in lymphoma, higher tumor bulk, higher LDH level predict worse CRS or neurotoxicity. So
Why is that?
probably because of the larger T cell expansion that has to occur to combat the
And
disease.
you see massive increase in cytokines. We didn't mention there's a condition, HLH, which can be seen too, which is really hard to manage, persistent high fevers, pancytopenia, LFT abnormalities. So you really crank up the cytokine storm with these patients. So if you do it in the context of disease, you have like a feedback loop that's really hard to control.
When you talk about the costs and come down from $500,000 to 80,000, can you imagine a day where it's 20,000? Is there something about this that's scalable, or is this whole process so unbelievably complex that we're going to hit a wall and it's still going to be massively expensive?
So I do think it's going to get, so this is one of the other unique things about UCSF. There's very few programs in the US that are doing homegrown CARs. I think there's more in Europe, probably because of the financial incentive there. So the homegrown CARs are one, but there's also new strategies like doing local manufacturing. So you can rather than having to send it all to one part of the US. We also heard about a really novel way of using viruses to do you don't need to do an apheresis. You do basically in vivo gene transfer, then you would bypass the whole apheresis part too. So there's so much innovation happening that I think the cost will come down, but right now it is quite an expensive process. But as I think Tom says, it's still possibly one of the most cost-effective therapies because the alternative to CAR T is indefinite therapy with our other agents, especially in myeloma. And so a bispecific for 2 years would be quite expensive. Probably they're probably going to be about 30,000 a month, right? So potato.
Yeah, I was going to say, so autologous CARs, I think there's a limit to how much cheaper you can make them. We didn't mention anything at all about allogeneic CARs. So CARs produced from healthy donors and infused in patients. In both myeloma and lymphoma, I think the data have been mixed because there's problems with expansion of these products. But as the technology is getting better, there could be a time when these off-the-shelf products would be cheaper and more available.
And when you say we're making them, so there's no pharmaceutical company involved? Is that how does this actually work?
For which ones?
When you say we're making our own therapies, that we have a manufacturing at UCSF or at Davis, like that is, we're taking the patient cells and
yeah, so the company that's involved is Miltenyi, which makes the machines that we use right now, and it also makes the vectors. But with both of the research programs that we have going on, we're making our own vectors or our own products. So there's no companies.
I mean, it does bring up the other part of it, which is the scalability, the quality control, because it's not like just because you do a homegrown academic, you're somehow absolved with all of those QA things. So it is still important.
Yeah, it's sort of just hard to believe over the grand scheme of things, every place having its own massively complex manufacturing process, and QA is going to be the right way to go. But for now, that is the best way to do this.
We've done it with transplant, so stem cell transplant, right? It's an entirely homegrown process.
Yeah.
So when it started out, there were logistical complications that made it hard to do individually. But I think we could get there as an institution, as every institution could get there.
Great. Christian, do you have a? Actually, they can hear you. Go ahead and speak up.
Yeah, so I following up on Bob's question, and I think probably $80,000 to $100,000 is probably the limit of kind of marginal manufacturing cost. But I agree, in vivo gene therapies are exciting, and one of our faculty, Justin Clem, is working on some things that are not yet published that are likely to be groundbreaking in this space. But teclistamab, as you pointed out, $42,000 a month the cost. CAR T cells, roughly $500,000 product alone. How do we now take therapy that has 4 drugs up front, and lymphoma also, we have bispecifics coming? How do we, and you two are leaders in the field, how do we make sure that we create systems that not only create long-term survival, but are sustainable, and that we're actually incorporating assessments of value, so that we actually know how to make these decisions and know what our whole system can actually tolerate without breaking, right? How do we not just throw a nod out to the cost at the end of our talks, but to really incorporate that into the process of doing trials and thinking about trials?
I think it's a great question. By the way, this is our division chief, Krishna Komanduri. I think one of the unmet needs in myeloma is treatment-free intervals, right? Because historically, we treat everybody with everything forever. Yeah, maybe you water it down a little bit, but one of the potency of these products I think the goals is to give patients treatment-free intervals. With cilta-cel, I mean, it's remarkable. I have patients who were never untethered from the cancer center because they had 6 prior lines of therapy. Now they get cilta-cel, they're transfusion independent, product independent, and out 3+ years. So I think we need to go for that kind of, if you're going to do these expensive upfront therapies, there needs to be a trade-off that you can actually give long gaps. That would be the only way I can see the cost being justified.
I mean, in some of the bispecific antibodies, you cover that, give a lower dose or a less frequent interval, or some of the lymphoma ones are self-limited, give 8 doses. These are the little things we can do. Of course, we don't control the pricing production of the drugs, but CAR T may be a more cost-effective option.
And it's also worth mentioning with pricing, the BCMA bispecifics is probably like the closest to a statin we have in oncology. There's like 8 different companies that are pursuing this, with 2 approved, the 3rd one on the way. And one of the good things for that is the market, prices will have to come down, because how many BCMA bispecifics do you need? And I think, I don't think there's going to be a difference in efficacy, safety, convenience. It's going to come down to cost. So I think that's really important to have, because right now, most of our products have almost a monopoly, right?
Let me throw out a provocative statement, and that's that in every paper we write that talks about a clinical trial, we have to say we're in compliance with the Declaration of Helsinki, right? If every paper that we wrote had to have a statement acknowledging and in some way discussing how value or accessibility might be influenced by the trial at hand, I think we would get better at getting to the place that we need to actively think about things like quality adjusted life years and cost.
Yeah, all these things are very hard calls with relatively new therapies because the history of this is the price comes down over time, and that some of the innovation that's done at very specialized centers and everybody's inventing as they go along over time gets more standardized, gets scaled. So it's hard to sort of look at a given point in time and say, is it worth it or not worth it? You have to kind of look at the long haul. But you're right. I mean, if these things cost $1 million and aren't curing people, you're getting an extra year or two of life. It's hard to imagine that the system can afford that. But those of us who've been doing this for a while have been told for the last 50 years that the system can't possibly sustain its level of cost, and it seems to be managing somehow. Any other questions out there? Yeah.
I have two questions. Thanks so much for that presentation. You guys are a fantastic dynamic duo. Two questions. So one is, what have we learned so far about the sequencing of bispecifics and CAR Ts? So is it better to give one or the other? Do we have any preliminary information? Is it so immunosuppressive that we shouldn't give one after the other in any case? So that's question number one.
Sure. Yeah, that's a great question. So we obviously both fields are relatively new, so we don't have a lot of sequenced data. We do know in lymphoma that that the bispecifics are active, and I didn't show the data, equally active in patients who are CAR T naive or not. However, one of the risk factors of progression on a bispecific is prior progression on a CAR T, likely having to do with some kind of immune responsiveness that we don't know about. There were some interesting early data that maybe bispecifics are less likely to lead to exhaustion, T-cell exhaustion from the lack of TON activation. But that hasn't really panned out so far in the limited studies that we have. So I would say they're interchangeable in terms of how we give it. The decision may be made for us by the drug companies because bispecifics are easy to combine with other agents. So they're being studied in the frontline setting, they're being studied in the second line setting. So if there is a frontline bispecific that it shows superiority to standard treatment, then everybody will be exposed to bispecific when they go to CAR.
I'm sorry.
In myeloma, we have actually pretty good data about that, which is first, there's the target issue, right? So for example, we didn't talk about it, but there's GPRC CARs. When patients get GPRC CARs, the biallelic loss of the target or protein expression is very high. In one study, it was 6 out of 6 patients. So if you're going to do that, that's not a good strategy to do the GPRC CAR and then try to do something afterwards. Then with BCMA, monoallelic loss is less common, so you don't get as much biallelic loss. But we now know that that cilta-cel, which is the reigning queen of myeloma, 3-year PFS, it drops to 5 months if you've given a BCMA bispecific prior to that. We don't think that's necessarily antigen issue because BCMA biallelic loss is rare. I think it's a T-cell exhaustion issue. So it goes back to, and perhaps lymphoma, they may not see it as much because they're giving fixed duration bispecifics, right? So in myeloma, we keep going over and over and over. So, and all of these initial phase 1 studies were at full dose intensity till progression. So maybe the data might change if you did lower dose intensity fixed duration and then went to CAR T, but we don't have that yet.
And when you're choosing to go lower dose intensity, is it because of patient-specific prognostic factors, or it's just we're going to try a lower dose in everybody and see how it goes?
So it's really fascinating. When I was involved in that phase 1 dose escalation study, some of those AEs we didn't even see at the beginning, right? Because the way these studies work is like, okay, dysgeusia, rash, you're like, oh, not related, not related. And then when you're like, oh, every patient's getting it, wait a minute, it's related. So there is a dose response in terms of both efficacy and toxicity. So the initial doses were selected at the RP2Ds because of the maximal efficacy. But because the median time to response is 1 month and the median time to max response is 3 months, and because they're durable, we now know that you can back off. So that's where that's happening. Like, it's not 100% response rate. So you got to capture the disease. But if you're lucky enough to capture the disease, then maybe after 3 months, you back off, mitigate those toxicities, mitigate T-cell exhaustion. And that's what we've seen preliminarily, that when you do less dose intensity, you're actually getting less co-expression of T-cell exhaustion.
But you'll do that with everybody. It's not like your
No.
patient has particularly severe presentation.
Maybe
right?
not
Or
like
higher dose.
extramedullary. No, we got to start. We start everybody at the approved RP2D, but then back off in the patients who are doing well. I don't know if you have a difference.
No, I mean, it's 2 different targets, thankfully for us, so CD19 and CD20. And so we don't have a lot of cross-reactivity problems.
You have another question?
Yeah, just I guess a prognostic question. So in the expanding multiverse of cellular therapies and bispecifics, there's going to be, as you know, new bispecifics for solid tumors and CARs for autoimmune diseases and neurologic diseases. So like 5 years from now or so, do you foresee patients being treated on the medicine floor with bispecifics and having medicine teams managing that? See more outpatient CARs happening. What can help with expanding access to these products?
And we'll have a CAR-T hospital.
Great question. So I have to say myeloma and lymphoma, unfortunately, are the low-hanging fruit, right? Because you can get rid of plasma cells and lymphocytes. And yes, okay, you get bad infections. I don't want to minimize that, but it's the side effects are much more predictable than getting rid of, let's say, pancreas cells, right? Or neurons. I personally think bispecific antibodies will be used in the community. Will be used in the community, like Rituxan. When Rituxan was first developed, everybody was getting infusion reactions. Then we figured out how to manage the infusion reactions, and everybody's getting it, even in the little mom and pop shop. So I think bispecifics will be like that. CAR-Ts are going to need a specialized center just because of all the things that can go wrong. But I think once you've done 10 CAR-Ts, you know how to do them. It's not rocket science. So those centers can probably proliferate and therapy to many more patients than we're currently treating.
But then it'd be an interesting question: who takes care of those patients? Does that become, I guess the same thing was true with Rituxan and other meds like that.
Well, it's still being given by oncologists, Rituxan, but I think,
But not for.
but I think, yeah, but it's used for all diseases, right? It's used for all, yeah. So I think anybody with basic medical training could do it.
Yeah.
I completely agree with the CAR-Ts are going to be limited, but the bispecifics, their whole intent is to be used in community, right? Because CAR-Ts are so few, in myeloma, it's kind of interesting. I think there are some studies that suggest only 12% of patients who are eligible for an autologous stem cell transplant actually get it. And it's very cost effective. So CAR-Ts, which are even more expensive and more limited, I think the number of patients that are going to really be impacted is low. So the bispecifics, but I can tell you when we speak to community now, no one's taking them, right? Even though they're FDA approved, everybody's scared about the REMS. REMS is this program that the FDA mandates that everybody needs to be trained. That's a big turnoff. I can tell you when I was in these phase 1 dose escalation studies, I got more calls in the middle of the night for CRS on those products than I've had in my entire career prior to that. CRS does not happen at convenient times. You need to have an infrastructure of people that are willing to take those calls. You need nurses that know about CRS. You need, and so one good thing is that, like right now, we finally agreed on harmonized CRS management, right? So for heme malignancy, bispecific and CARs, we have a protocol. So the hospitalist or the nurse on call, they just follow the protocol. They only need to call us if there's something that's not going well. But so you can, I think, get to the point of monoclonal antibodies, but I think I would use monoclonal. I was going to say the exact same thing. It's the way monoclonal antibodies have evolved. I don't think it'll ever be on a regular medicine floor unless it's those specialties have been trained and the nurses have been trained.
Is treating myeloma in the community, is that standard of care now, or do you think all those patients need to come to a place like that?
I mean, the vast majority of patients are being treated in the community with myeloma, right? And so,
I mean, historically, they've been referred to UCSF because of the need for stem cell transplant. That's how they get captured. But maybe you can speak to the future of stem cell transplant for myeloma.
It's another great round.
Yeah, exactly.
Time for one more. Any other questions out there? Yeah, question.
The homegrown CAR T cell or CAR T therapy, is that actually patented and manufactured at the institution?
At UC Davis right now.
Yeah, I'm doing it at the UC Core and UC Davis, right? So it's a commercial. So I don't know if people are familiar with the Miltenyi platform, but Tom Martin calls it an easy bake oven. So they sell you the machine.
Very expensive.
They sell you the machine. It's closed circuit so that you have the reagents. They send you the viral vectors. So all you put in are the patient cells, and then 3 to 9 days later, you get out the CAR T product. So all of that is serviced by Miltenyi, is patented by Miltenyi. We just provide the facility, the GMP facility. That doesn't even require GMP actually. However, many people are tweaking the machine to use their own viral vectors, to use their own kind of condition. So that's the kind of thing that we're working on right now.
And in the tweaking, is the FDA approval sort of limiting?
It
what you
requires-
can and can't do?
No, I mean, you're required to do trial runs and see, show them the safety of the vector and the product is doing what you're expecting it to do. So there's a lot of pre-IND work that goes into it.
It's just not like it's not like here's a drug that the FDA approved.
Right.
Because sort of reminds me of artificial intelligence, like it's not a static product over time.
Correct.
And so an approval is kind of tricky because you're tweaking it.
Right. Every time you tweak it, you have to get permission from the FDA.
I wish quick, thank you. It's fascinating. Thank you. Amazing work. You guys.